Memory is often treated as an abstract concept, a personal archive of your history. Clinically, however, memory is a strict mechanical ability to process information. This process is built on three distinct mechanical nodes. First is registration. Data must accurately enter the system. Once registered, that information moves to the second node, retention. The brain must hold on to this data in a stable buffer. Finally, there is recall. When needed, the system must successfully extract that specific piece of data from the retention buffer. When a patient presents with a memory disorder, they are not suffering from general mental fatigue. They are experiencing a localized breakdown within one of these specific mechanical nodes. Whether caused by physical damage or severe psychological trauma, the cognitive pathway shatters, completely interrupting the flow of information. To accurately diagnose these patients, clinicians map the taxonomy by dividing memory disorders into two strict categories: quantitative deficits, which measure a drop in the volume of memory, and qualitative distortions, which measure the accuracy of the memories that remain. Mastering this mechanical breakdown is the essential foundation for isolating patient pathology and a strict requirement for passing clinical viva examinations. To pinpoint where a mechanical failure is occurring, clinicians test the patient's retention phase across three strictly defined temporal axes. This diagram illustrates these limits. The first axis is immediate memory, a fast-draining container lasting a few seconds. We assess this by asking a patient to repeat digits immediately. The second axis is recent memory, holding data from minutes to hours. The standard clinical assessment for this axis is simple. Ask the patient what they ate for their most recent meal. The third axis is remote memory, encompassing the long-term past. This is evaluated by asking the patient to recount childhood events or verifiable details from their distant life history. By systematically probing these three timeframes, clinical exams isolate exactly where the retention timeline is failing. With the temporal axes established, we look at quantitative disorders, conditions defined strictly by a change in the total volume or amount of a patient's memory. The most severe of these is amnesia, the total loss of memory volume within a specific temporal window. This timeline introduces a trauma event line. To differentiate amnesia types, we mark the exact moment an injury or psychological break occurs. In anterograde amnesia, past memory remains entirely intact, but the patient loses the ability to form any new memories after the event line. This block is commonly caused by localized head injuries and severe physical brain trauma. We also observe it as a progressive, degenerative symptom in Alzheimer's disease and Korsakoff syndrome. Retrograde amnesia works in reverse. The ability to form new memories remains normal, but past memories from before the event are completely wiped out. Like anterograde amnesia, profound physical trauma to the brain is a primary cause. It is also a known and often expected clinical side effect of electroconvulsive therapy. Identifying whether the memory void exists before the event line or after it instantly narrows the clinician's differential diagnosis. There are distinct variations, such as transient global amnesia, a profound memory loss where the patient typically makes a full recovery within hours. Then there is dissociative amnesia. Here, the memory loss is driven purely by severe emotional stress, presenting with absolutely zero organic brain damage. This visualization maps shifts in the brain's total memory capacity. Hypomnesia is a decreased global memory, heavily associated with dementia and depression. On the extreme other end, hypermnesia is an unnaturally increased recall capacity, observed in mania and autism. This distinguishes localized structural amnesias, which present as missing chunks of time, from functional global states, which act as a general dimming or brightening of overall cognitive volume. Quantitative disorders deal strictly with volume. Qualitative disorders occur when the memory volume is technically present, but the actual content, or the feeling of familiarity attached to it, is corrupted. This timeline highlights empty gaps filling with mismatched data, a state clinically termed paramnesia. A major paramnesia is confabulation. The brain unconsciously fills gaps with fabricated stories, and the patient believes these patches to be absolute truth. Clinically, we heavily associate confabulation with Korsakoff syndrome, which traces back to chronic substance abuse, specifically alcohol toxicity. Paramnesias also include familiarity errors. Déjà vu is the false sensation that a completely new situation is highly familiar. The exact inverse is jamais vu, the sensation that a highly familiar everyday situation is suddenly strange or brand new. These familiarity errors are tied to specific biological triggers, including temporal lobe epilepsy and extreme acute anxiety. In all paramnesias, the brain attempts to patch gaps in its own processing. It turns a structural deficit into a vivid psychological distortion. This matrix maps the taxonomy. Every symptom traces back to two causal categories, organic or functional. Organic causes involve structural brain damage, including trauma, stroke, dementia, and substance abuse. Functional causes have psychological origins. Processing is disrupted by severe stress, trauma, or depression. Whether a patient presents with anterograde amnesia or vivid confabulation, the symptom leads the clinician back to either a physical brain lesion or a psychological overload. The VIVA assessment exists specifically to navigate this matrix. Asking a patient to repeat digits, describe meals, and recount history systematically maps the scope of the defect. The prime directive of management is clear. You do not treat memory loss. You treat the underlying organic or functional cause. The etiology dictates the pharmacology. A patient with functional depression requires antidepressants, whereas an organic dementia diagnosis points toward cognitive enhancers like donepezil. When organic memory loss reaches an irreversible stage, the clinical focus pivots entirely to nursing care. Environmental interventions act as the patient's external memory. This requires continuous reality orientation regarding time, place, and person, providing memory aids like diaries, and maintaining a strictly safe physical environment. Diagnosing a memory disorder requires isolating the temporal timeline, identifying quantitative loss versus qualitative distortion, and addressing the biological or psychological root. Human memory is the mechanical foundation of a patient's present reality. Protecting it requires precise, methodical